We now know what diastolic dysfunction is. We know that it is very important, and we also know which modalities we have to assess diastolic dysfunction. But now we need to go into more detail so that we can actually grade the severity of diastolic dysfunction. First, we have to look at the different components of diastolic function, and this is best done with the help of the mitral valve inflow signal. We have two components, an E wave and an A wave. E wave is early filling, and A wave is late filling caused by atrial contraction. Early diastole has always been referred to as a passive process, where we have a gradient between the left atrium and the left ventricle, which pushes the valve open and which allows blood to flow into the left ventricle. In reality, this is not completely true. Even early diastole is an active process. We have active relaxation, and it is the ventricle which applies suction, at least in healthy individuals. Many factors play a role for early diastole: the internal loading conditions, contractility of the left ventricle, wall stress, and atrial impedance. To better understand early diastole, take a look at this animation. Remember when we talked about systolic function, we mentioned that the heart in reality has a twisting motion. Well, during diastole, it has an untwisting motion. And it is the rate of this untwisting motion which describes diastolic function. In other words, we're looking at this part of the curve, the steepness of this curve. And we can describe the steepness with tau, which is the rate of relaxation. Keep this in mind when we look at patients. Back to the mitral inflow signal, let's talk about the A wave. The A wave reflects atrial contraction, and the magnitude of the wave correlates with two things: the magnitude of atrial contraction and also the amount of volume which is in the left atrium at the time when the atria contract. In addition, the A wave is also influenced by the compliance and the filling pressures. But let us not make things too complicated. Let us discuss the typical inflow patterns. First, the supernormal pattern. Where does it occur? In young, healthy adults, usually athletes, and patients who have very good systolic function. The typical pattern of supernormal is that we have a very tall E wave and a fairly small A wave. Why does the curve look the way it looks? Simply because we have very strong active relaxation in the early phase. In other words, a very rapid and vigorous suction of the left ventricle because diastolic function is supernormal. Remember the diagram or the illustration I showed you previously? We have a very rapid untwisting of the heart, and therefore we suck the blood into the left ventricle very quickly. And since most of the blood is already in the left ventricle, the atrial contraction does not really contribute very much to the filling of the left ventricle. In normal hearts, we have fairly little resistance to filling, in other words, good compliance of the left ventricle, and we have pressure gradients which allow probably 2/3 of the blood to flow into the left ventricle during early diastole. Therefore, we have a signal which looks like this: an E wave which is taller than the A wave. More blood during early diastole versus late diastole. If we have a diseased left ventricle, for example, left ventricular hypertrophy with fibrosis, then we have a stiff ventricle, a ventricle which loses its compliance. In this situation, we have difficulties in filling the left ventricle. We have a drop in the pressure gradient during early diastole, actually. So the curve looks like this. We have a small E wave and a large A wave. So the E wave has dropped and the size of the A wave has increased. Again, why? Because we have less pressure gradient during early diastole. We have a lot of residual volume of blood in the left atrium during the late phases of diastole, and those are pumped into the left ventricle via atrial contraction. What else is there to mention? We have a fairly long deceleration time. Remember, we usually have normal or only mildly elevated left ventricular filling pressures. This pattern is called impaired relaxation. So the size of the A wave, and in particular the area under the A wave, so nicely reflects the component of atrial contraction for left ventricular filling, especially if you relate it to the size of the E wave. And if we get older and the ventricles get stiffer, we have more component of atrial contraction, which is relevant for filling. This is also the reason why it's so important to maintain sinus rhythm in patients who get older and in patients who have stiff ventricles. But what happens if the ventricle gets even stiffer, if compliance drops even more? Well, we have to then compensate. We need an elevated left ventricular filling pressure to maintain the gradients to fill the left ventricle, and thereby allow filling during early diastole. So the pattern will reverse. Again, will we see a pattern where we have an E wave, which is taller than the A wave. And because it looks very similar to the normal pattern, we also call it pseudo-normal filling pattern. The only difference in reality is that we have a deceleration time which is shorter, in other words, a steeper curve than in normal patients. And what happens in patients where left ventricular compliance drops even more, or where we have very high left ventricular filling pressures, for example, in patients who have severely reduced left ventricular function? Well, in such a case, we have to have very high left atrial pressures to fill the left ventricle. Therefore, the signal looks like this. We now have a very high and tall E wave. Again, we have a lot of filling in early diastole and only a small A wave. So actually a very similar signal as we had it right at the beginning when we talked about the supernormal diastolic function. Only this time we also have a very, very steep deceleration time, and this time the A wave is not tall because we have suction, but because we have such high left atrial pressures. So the typical curve in restrictive filling pattern is that of an E wave, which is twice the size of the A wave. In this situation, we have a very high left ventricular filling pressure. And so if we put all this together, we can grade diastolic dysfunction. And remember, since diastolic dysfunction largely reflects left ventricular filling pressures, it also nicely reflects the severity of symptoms. Okay, we have grade 0, which is normal, where we have an E wave, which is taller than the A wave. Then we have abnormal relaxation. We have an E wave, which is smaller than the A wave. And we see a prolongation of the deceleration time. Grade 2 would then be pseudonormal, a pattern which is similar to the normal pattern. However, we have shortening of the deceleration time. Then we have the restrictive filling pattern, where we now have an E wave, which is twice the size than the A wave. And then we have grade 4, which is also a restrictive filling pattern, with the only exception that we cannot reverse this type of pattern back to a pseudonormal pattern. We would call it irreversible. We'll talk later about how we can actually reverse a signal. Here too, do we have a shorter deceleration time. As a matter of fact, the higher the left ventricular filling pressures are, the shorter usually the deceleration time gets in restrictive filling pattern. One problem in the assessment of diastolic dysfunction is the differentiation between a normal and a pseudonormal pattern. The normal pattern has a fairly long deceleration time, while the deceleration time is much shorter in patients with a pseudonormal pattern. But you can also solve this problem with the help of tissue Doppler by looking at the size of the E prime wave and the ratio between E prime and E. In patients who have a normal diastolic function, we have a fairly large E prime with more than 10 centimeters per second and a small ratio. In patients who have a pseudonormal pattern, we have a small E prime and a fairly large E to E prime ratio. In other words, a value which reflects elevated left ventricular filling pressures. Here's an example. We have an E wave which is taller than the A wave. Now, is this normal or a pseudonormal pattern? To solve this, we perform tissue Doppler. First of all, we see that the E prime is above 10 and that the ratio is 7. In other words, we have normal left ventricular filling pressures. So normal values are below 8 to 10. And this means you have a normal and not a pseudonormal pattern. One other thing you can do if you really want to get a value for the filling pressure, you can use this formula. You can also abbreviate this formula by calculating the E to E prime and then adding somewhere in the range of 4 to 5 to this value. Then you get the absolute filling pressure, approximation at least of it. So in this case, it would have somewhere between 11 and 12, which is still normal. Can we also use the pulmonary venous flow signal to help us differentiate the different forms of diastolic dysfunction? Yes, we can. We use the right upper pulmonic vein. We have to consider that we have a decrease in the systolic component. We have an increase in the atrial contractile part of diastolic dysfunction, the late part of the curve, which is the retrograde curve. So a taller AR and an AR which lasts longer. So the duration is also increased. Here's such a typical signal. We have the systolic component, which is taller than the diastolic component. And here we have the retrograde diastolic component, AR. To be honest, I don't use the pulmonic veins very often. Why? It doesn't always work. It's difficult to get the signal. Only in 60% can we get an adequate signal. And the analysis is fairly complex. Measurements are very inexact, and it doesn't work in patients who have tachycardia and in patients who have atrial fibrillation. But if you want to be a real diastology geek, here are the typical curves for mitral inflow and also for the pulmonic venous flow. Again, in normal situations, you have a small systolic component which tends to first increase a bit and then decrease as the filling pressures rise. At the same time, we have a gradual increase in the size and also in the width of the A wave. So what are the key issues to remember? Well, we primarily use the mitral inflow signal to quantify diastolic dysfunction and to get an estimate of the filling pressures. We use the tissue Doppler to get a numeric value for the filling pressures. And if you still have time, and if you still have questions or problems or ambiguous situations, you can also use other modalities, such as, for example, the pulmonic flow.